Yeah. So it's really quite easy if you have a YouTube channel, which we happen.
That's cool.
It is. It's actually great because these YouTubes are too big. They're almost a giga. Well, they're multiple. They're just huge sometimes, especially if they go over an hour. So you can't really use them effectively. But YouTubes are really easy to use. So I'll start this up and we get started here. So today, let's see. Somehow, I'm not going to show this for a second here. So I thought today we would really just spend some time mostly on kind of debriefing from yesterday, having a chance while it's still, the half-life is what, 12 hours or something, to be able to remember and just to kind of sort of capture some thoughts or review some stuff. I put a couple of slides together on, it was interesting, the ones I sort of copied were more of the privacy and confidentiality ones from the beginning of the session, and then a couple of other links and things like that. So I just wanted to sort of provide a space and some time to talk and kind of see what people heard and what we learned and kind of questions that came up and kind of getting prepared to what might be next. I did invite all of the ONC people, so I don't know if anyone will show up. I kind of doubt they will, but who knows? So we'll see who joins us today on the call here. And there are a couple of new folks who joined as a result of the event. And so there are a couple folks with us here today that I would, or some that I've known before, a couple of new people here, I think. So what we do is just ask you to kind of introduce yourself and say a little bit about where you're, and then we'll kind of move forward from there. So Chuck, I think we had the most latest conversation, so welcome.
Thank you, Daniel. I'm Chuck Kerr, and I'm a privacy attorney focused on consumer transparency issues around consent, and was very excited by yesterday's presentation. I guess all roads lead to Rome because I worked with Jim Sinclair last year on the Good Health Pass interoperability blueprint, and I also ran into him in joining the Helios Sapphire Accelerator for the working groups. So I guess it is logical that I be joining all of you who it seems to me, are doing some of the deepest thinking about the capture and representation of consumer consent across different legal regimes, which is really the thing of greatest interest to me. So thank you for including me.
Welcome. Yes, it's all, be warned, it's all now becomes 1 degree of separation for the rest of the world. And that's interested in these topics. So I'm glad that you're here. I'm glad that you're connected on the Helios stuff as well. I want to talk more about that. Denny, I feel like we've connected, but I'm not sure on this call. So
once before, Daniel. Okay. I'm delighted to be back. It's exciting to see the work that's being done in consent as interoperability advances. This is a critical foundational point for interoperability, which is what our organization, the Massachusetts Health Data Consortium, is up to our necks in right now. So learning more about the best thinking on consent is certainly a great opportunity, great privilege for me. So thank you for the opportunity to join you.
And I have to throw a plug in for Denny. He's going to be on our next podcast. So Daniel, I know we had you on, but I just saw the final version, which should be released next week. So I can drop that link in. But yeah, they're doing great things up in Massachusetts. So you guys should listen if you have a chance.
Continuing to do great things in Massachusetts.
Yes.
I'd be interested in wrangling you to, after you do your podcast, maybe to come back and talk with us about it, because Massachusetts has been on a tear for years now, especially around the not psychotropics, but the opioid work. We connected, Adam and I particularly, with Massachusetts a while ago, and just you were bringing everything together to really get the information all across it looked like, the slideware looked great. So hopefully the implementations met the slideware. I'm just joking, yeah, but that'd be great. Pooja, send it when you get that done. Let us know, and we'll push it.
I
on
will.
up.
Actually, I'll just put the link in because you guys can listen to Daniel's episode too then.
There you go. That was fun.
So, yeah.
I feel lucky to have been asked to participate. That was great. Dawn Bonder, it's been a while. Welcome.
It has. Nice to be here.
Greetings.
Kind of in a witness protection. Oh, there, a little bit of light.
That's excellent.
Good to see you. I'm here on behalf of Medado Health, and I see my colleague Pete Robinson is here. Carol Robinson would like to have been here, but she's at MESC, so
Yeah.
I assume she's deep in doing what she went there to do. So sitting in her stead, big shoes to fill, but listening and taking notes. Please don't rely on me for a whole hell of a lot of jumping in and heavy participation, but following.
Well, no, but also from yesterday, you were on some of the sessions yesterday, right?
I was not. I was
Oh,
unavailable
okay.
yesterday,
Oh,
but I
sorry.
think Pete might have been. So
Yeah,
it's good that
yeah.
Pete is here.
Yeah.
So yes, there we go.
Hey, Pete.
Hi, Daniel. Nice to hear your voice again.
So we worked on, Pete and Dawn and I actually worked on an early childhood scan in California with the Heising Simon Foundation a while ago, which actually led us to Christine way back when we were trying to learn about the crazy world of, we think human services is fragmented. go to home visiting and early care and education. It's really the Wild West. Oh my God. What a mess.
The Wild West with a lot of very skilled people trying to carve out their territory.
Yeah. Yeah.
I just want to say hi to Dawn. Hi, Dawn. Been a long time.
I know. Hi, Adam. Good to hear you.
Yeah, ditto here. Ditto here.
So let's see, who else? Anybody else that is new to this call? Nat?
Hey,
Who else?
hey, Daniel. This is Natalie Pagler.
Yeah. Just remind us and me.
Oh, sorry. Hey, sorry, everybody. I'm only on phone, but this is Natalie Pagler. I'm the CMIO at Stanford Children's.
Oh,
Yeah, and we've been doing a lot of work on adolescent. It ends up tying into the consent process, but it's more adolescent information sharing versus guardian sharing and information segregation and that type of thing. And so and have done a couple studies demonstrating that we often have poor identification of who's on the other end of our portals, and that guardians are actually managing and accessing more than 50% of their adolescent portals. So it just adds to the digital identification issues that you would need prior to consent.
that's really interesting. I thank you for reminding me. I saw Nat and I just didn't add the link to it. I didn't
Sorry,
get the
I'm on my
Natalie
phone and it
part.
doesn't have the, I didn't realize it didn't have my name on there. Yep. Sorry.
Wanted to be.
That iPhone too. So there you go.
Yeah, that's what I get for being on phone. Sorry, I'm unfortunately only available till 2, so I have to drop off. But yes, thank you for inviting me.
Yeah, that's great. No, and I'm glad you're on because I know you participated and presented yesterday, right? And some interactions, or especially around the adolescents and some of the questions that came up there. So greetings. So welcome. So as I said, I just put a couple of slides together, but I kind of see this as an organic kind of conversation emerging, unless actually I was going to just ask before we dive into that, Brian, Eric, Matt, Dave, anything that you guys, any updates to relevant stuff around aging or the next steps on the Connect-a-thon or the NSF grant coming up?
I have two announcements. One is that, of course, next week is going to be the Direct Trust and Civitas annual conference down in San Antonio. For those of you who are interested, I think you can still get virtual seats to the shindig, though they maxed out their face-to-face participants quite a while ago. We are continuing to develop tracks and user stories, et cetera, for September's HL7 Fire Connect-a-thon. So there's work afoot there over the course of the next 4 weeks. So something to look forward to.
Hey, Daniel, just another, I don't know if you guys saw, I figure it's probably worth mentioning to this group that the Gravity Project announced that they're going to start holding pilot meetings for folks that want to get together to talk about if they're piloting anything. So I can drop that link in. I think they made an announcement last week. So they're going to start doing, I think, monthly meetings for implementers and folks that are interested in implementing the Gravity Project stuff. So I feel like this group would probably be interested in that.
And it's probably worth mentioning that they also just announced that their Gravity Community vocabulary working group is going on a hiatus for the time being because they don't have funding for that particular aspect of what they're doing, though the pilot work is being funded by the ONC and AERP Foundation, amongst others.
Yeah, I saw that. Interesting, but I'll drop the link in. You guys can sign up.
I've got, let's see, Friday is the semi-monthly ontology, human services and ontologies working group meeting. Right now, we have an open kind of just a discussion agenda, but I want to talk about the NSF Open Knowledge Network, where that project is leading, the sub projects that they're considering funding, and you know, all of that's knowledge graphs. Also, I want to discuss the DVPD's Linkmaster 3000 tool they're coming out with. That seems pretty cool. And
Translate.
You have to attend the meeting. It's kind of a deep topic.
Okay.
It's got a great geeky name.
I think it's hilarious, but yeah. Anyway, and then maybe they'll rename it when it goes live. I have no idea, but it's tools for knowledge graphs. And then also related, I want to go over the updates to the Solid project, and quickly discuss the decentralized ID standard that W3C has sent to a recommendation, which means it's a standard. I guess they just like being soft about their things they say. And some updates in web IDs, and then a quick update on the HUD HMIS ontology. And also some conversations I'd like to talk about, you know, and I think Ryan and I have talked about this a lot, but, you know, additional work on generalizing some of the concepts in FHIR, just so they can even link up with external constructs. There's some work going on in that area. And if anybody has more updates, that'd be great to go over at the meeting. And then outside of that, so my employer is named BitFocus, and they're a homeless management information systems vendor. They're one of the, I'd say, 2 top ones. They have most of the large cities as their customers. And we would like to, HUD has, in June 22nd, they dropped a notice of funds opportunity for unsheltered homelessness. And a big segment of it is housing and homelessness and healthcare integration. So what I'd like to do is I'm going to attend the Baltimore, probably not in person, but the Baltimore Connect-a-thon, and look at how we can do a little work there. But the main thing I'd like to do is take 2 communities of our customers. We haven't determined exactly which ones yet, but use those as affinity groups for the upcoming gravity project starting from September through December. And the conventional wisdom is housing doesn't coordinate well with fire, but we like to show that we can both send fire questionnaire responses from an HMS, and we also like to process closed loop referrals. So if anybody wants to help me out with those tracks or be a part of that process, I'd really be excited to help work on that, with the goal of going live with it sometime well into the future.
Eric, do you record those meetings?
We don't. Yeah, we should. It would be nice.
Yeah.
Wouldn't it? I'll think about that. We do them on Google Meet, but but let me think about how we might be able to record those and post them on YouTube.
Yeah, I think that would, as we get rolling, and more people need to get educated about some of these pieces. That whole, even yesterday I heard, not even yesterday, but yesterday, I can't remember exactly where, maybe others heard this discussion around ontologies. I don't know if that was in the panel, Jim, that we were talking about, or where it came up, but I thought, because you were on some of those sessions, right? I don't know. If
yeah, they just jammed us into random work groups. We always didn't always know why, if that was a good alignment, but yeah, no, I wasn't. I don't think I was in that one.
Yeah. Does anyone recall that?
I was in yours. I was in Bert the first one, and then I was in yours in the second before our session.
Maybe it
There was some stuff in the chat, Daniel.
Was that it? I copied I saved the chat, but I didn't look at it yet. I remember hearing
You were able to download the chat, because I have not been successful on previous ONC webinars.
Yeah, well, weren't you a co-host?
Oh, yeah. Good point. Yeah, that's right.
They made us co-hosts. So it's interesting. They just used Zoom, just regular commercial grade Zoom.
Yep.
Yeah, to run it, which unfortunately I think was, while it was simple because everybody knew how to use it really pretty well. It doesn't allow it's hard to get breakouts like the second group without randomly assigning people. You can't do it on the fly very easily, and I don't know if anyone can do that, but I'm not sure they maximize the opportunity, because people got put in stuff that they didn't really know about or care about necessarily, and there were a lot of good topics. I know it'd be one thing to kind of hear, because I think we probably covered. I know that Mary Sarah's still on here. You were in one. We were in one. Who I'm sure Eric we were probably covered 5 or 6 of them, I bet. Be interesting to hear if people felt like there was a good engagement. What do you think? Mary Sarah, did you do your, I know you're at MESC, so I don't know if you're.
Yeah, no, I don't think there were, I think we had one question. Baka, is that right? One question?
Yeah, we only had a couple of questions. I can review our chat, but one question was about why we propose using the Fire bundle. And I explained that was just one of the possibilities. I don't remember what was the other one.
Yeah. So it was pretty quiet, Daniel. We had some extra time at the end, so we didn't run out of time.
Interesting. Anybody else?
Maybe Natalie can talk about her session.
Yeah.
Yeah, I was just going through again the work that we've been doing, kind of sharing the work that we've been doing with adolescent information sharing, getting repetitive there, and some of the issues that we've been running into with the identification piece of it. So I did a short presentation on it, or it ended up, about 20 minutes of it, and then and then we started some conversation and got cut off. I thought we got cut off before we ran out of time, because I thought we had a few more minutes when I was looking at my time. All of a sudden it was like you're mid-sentence and we got cut off. But there was actually, again, you know, I feel like my stuff is a little bit different, and it is kind of even pre the consent piece of it. It's really more about the identification piece of it. But there was actually quite a bit of engagement about that, and a lot of people, there were some questions in the chat, and then, or some ideas in the chat, and some questions, but we got cut off pretty quickly. I thought one of the pieces that came up, that I, at least for some reason, had not registered before, is that there isn't yet a FHIR resource around family members or caregivers that are part of your family, and that I don't know why that was so shocking to me, but it's like, it was like an aha moment for me. Like, that is something that we so badly need for some of the issues that I face with proxy consents and all those types of things. So I thought that was an interesting comment, but it was a good discussion. But again, a little bit, it's closely aligned to this topic, but it's you know, there's so many different pieces of this word.
Yeah, Natalie, I had a similar moment like that when somebody clarified, and I just never considered it. I always thought a person was a person, but they distinguished. I can't remember who made the distinction, but it seemed from a position of knowledge, so I trusted it. But you know, a person is a person not receiving care in FHIR. It is not a person on the street, and then a patient is a person, you know, receiving care or in some sort of, you know, clinical or whatever, you know, getting some procedure. So, you know, I thought, wow, that's not a person that we can connect to with our ontology mappings. Likewise, what you said, you know, we have HUD households, which are weird. And then we have, which are like co-enrolled people. It's not like a, you know, a global household or some concept like that. So they do have, HUD does have a global household concept, which would be kind of related, I think, to your, you know, the I don't know, the family members concept. And so, you know, we got to, both sides have to kind of go up a level, you know, like what Brian's talked about a lot, Brian Hanspicker, in the meeting today, about like the, you know, core ontology or something. We got to back it up a little bit so we can connect things. Because right now we're all too much in our own little, you know, weeds, and it's hard to map between them at all.
Yeah, absolutely. You know, I mean, I think especially when you're talking about consent, it's not only being able to identify a person who's not a patient, but that relationship. There is no digital documentation of a guardian relationship, right? Birth records, for the most part, aren't electronic. If you lose guardianship, it's all on paper. Like, you have these poor foster parents walking into the hospital with packs of paper to try to establish that they're the current guardian for a patient. So, like, thinking about how do we electronically establish the proxy or the guardianship relationship is critical to consent issues.
Right. And I wonder, yeah, is that guardianship relationship sort of a legal thing that could span to, you know, FERPA and maybe other, you know, HUD households and stuff like that. I wonder if we can get something generic there.
Right, it should, you know, and again, it's not even a pediatric thing, because the same thing, and I'm sure we've all faced it. Like, I'm dealing with my dad right now, and like, you know, and just and you know, showing that I have proxy access for his healthcare and what I could and can't sign for, and that kind of thing. You know, as you talk conservatorship, like, when you're talking consent, it really establishing again that guardian has the right to consent for them is huge.
Yeah, Ryan and Alan and I were just on the Care Equality Patient Identity Working Group meeting before this one. And for the last 2 weeks, for the full hour, it's been on proxy access, really from the standpoint of identity verification and making sure you can confirm the proxy in some way and that you're connecting the proxy to the right patient. And we haven't even gotten into the consent and guardianship model yet.
Yeah, this is what people were really interested in the childhood session yesterday too. They said, how do we even know this is a custodial parent? So
yeah.
that was sort of like the key question.
Yeah. You know,
yeah.
And I think to some degree, I mean, that's going to be a really hard one. If we wait till everybody standardizes that to move forward, that's going to be a big impediment. There might be a point in time where we would do better to maybe allow organizations to kind of do a verification and have that trusted network so that you are trusting what they're doing and move from that to standardization instead of trying to start with the standardization.
Right, just copy the existing workflows because this work is done already in the real world. Just use whatever verification process they use now, even though it's
But
not
it's done
great.
differently. Yeah.
For the most part, I mean, the crazy thing, for the most part, how this is done, if you ask children's hospitals, is if the person shows up with the kid, they assume they have custody. And that's how you establish it. And so the whole COVID thing was huge because suddenly they weren't showing up in person. And so we had huge issues about, you know, and there's a lot of trust, but I mean, it's a major ongoing challenge. But I agree with you. I mean, I think, you know, this is, you know, totally the example where you don't want perfect to be the enemy of the good. And so if they have done their verification process, as poor as it may be, accepting that from an outside organization is better than what we have now, which is you really have no idea.
Yeah. And there's variations, like with tribal communities, they can be, the families can look a little different, and you would probably want the people who are interfacing to be the ones who are making that determination, not a standard that may not apply.
Yeah, again, it's so complicated because you know, trying to do, I think, you know, for the most part, doing what's right for the child is working with the person that is, you know, with them and caring for them. But there are I think, you know, fortunately, fairly rare circumstances where you do have people trying to do wrong, or, you know, like a non-custodial guardian trying to get access so that they can get information that may help with a custody battle or something like that. And so, you know, there are real cases of harm being done by not establishing this well, but for the most part, I don't know, you can also cause harm by making it too strict a process.
Yeah, it was interesting. The afternoon session that I got randomized into was of a technology called Prevo. And, you know, they spent a lot of time on how they did the two-factor verification of the parent to be able to assert that they really were who they were.
Yeah.
But not that they were that, they were still asserting that they were that child's parent, right? That wasn't questioned, or that they had legal, you know, right to give it. But then they had to really prove that they were them and not sort of the kid overcoming it. And then, you know, at least the examples that they gave were using technologies that would not be, or sources of verification that would not be available to a lot of parents that I've worked with. I mean, they were asking for social security numbers and credit cards and, you know, things of that nature that a lot of my parents would not have. So.
Yeah, and to that end, Christine, we had a heated discussion, legitimately heated discussion last week during the identity management group, because the default position is to use something called IA level 2, identity assurance level 2. And they were saying, you realize if we use this as a default, there is a portion of the population that's going to be left out. And I think we're going to try and gather information from other exchanges and CMS and wherever else that they're using those identity proofing services for information exchange to understand, do we know what a relative population is that can't meet IA level 2, that doesn't have the identity characteristics for it, and how many people will be left out because of it?
Yeah, that was exactly my concern when I saw the presentation, and I did ask them in the chat. They ran out of time. They weren't done with their presentation, so we didn't get to ask any live questions. I did ask in the chat, and they said they had some other methods, but I didn't get a chance to hear what those were. But they're probably using exactly that standard that you're mentioning.
And I think the problem that you're posing, Jim, is it speaks to the importance of having community-based organizations in the workflow and empowering them with like technology, because they're like, when they're helping someone with a SNAP application, you know, they already have to prove that person's identity. They have to track down, okay, if they don't have a driver's license, what are the other acceptable forms of verification that the state, you know, Department of Social Services is going to accept So there's multiple documents, like all the things that Dr. McCoy is pointing to about, these challenges. It's like these are the trusted community-based organizations that like have experience communicating with someone on the ground on these things. And so part of my thought process is we have these initiatives around like bringing better identity management into EHRs is like, how can we really like engage with these community-based organizations that have those trusted relationships with the clients, the people who are being served, and empower them with the technology. So.
No, you're exactly right, Matt. And quite frankly, it boils down to, in many cases, just what the organizations are willing to accept for liability. What are the chances that I'm going to inadvertently disclose or breach PHI that doesn't belong to person X because I don't have enough confidence in person X? And obviously the high water mark is I want 100% confidence. And we all know that socio-demographically speaking, that's very difficult.
So the question I ask is, what's Pareto here? Right, so are we getting when we're doing identity proofing, are we getting 90%, 95, 98, 99, 99 and a half? Where is it? What's the range? Because
legit question, Daniel. And in fact, those are the sort of statistics we don't have. So I think that a healthcare organization should be able to say, any health, let's say a system, and I'll just pick on Stanford Children's since Nat's there, that they as a system happen to know if we use IL level 2 guidance for establishing identities, 35% of our patient population is going to be left out for various demographic factors that we need. If we start considering, what ONC is talking about, the IL level 1.7, that increases it to 75% of the population. We only leave out 25%. What is that balance? And then what does that mean in terms of, it's easy if the majority of that population always shows up face to face. If we're now pushing them out to telehealth verification or a mobile app, how does that change things? And we haven't collected those statistics as yet, but I think we need to.
I mean, Daniel, like in the forums for like open technology challenges, right, where you like have some kind of big prize money and you have a bunch of AI, statisticians, putting forward algorithms for person matching, right? I think they get to like 82%, maybe up to 88 at most, right? With, dummy data, right? But those are the only forms where you have this kind of very transparent process of actually verifying and validating that this match was done accurately. Companies typically do not want to broadcast that. They don't want to broadcast their methodology. They don't want to and so that's the problem. We don't, and it's also the need for standards. There's kind of like a chicken and an egg thing. Okay, if you develop the standards, will they come, right? Will people adopt these standards and say, okay, yes, this is how we're doing matching? Just to share one factoid I heard today about a large company whose name I won't mention, LexisNexis, who was at a conference and talking about the quality of their data for identifying with they could say with 82% confidence someone's race or ethnicity. 82%, that 18% leaves out, besides many ethnic groups, right? So that's just one data element, right?
But are you serious that LexisNexis doesn't? They have hundreds of data sets. I can't believe they don't have a 99.9% sort of.
But it's all based on the quality of the data that they get in the first place. You can only
it's all your credit card data. It's all of your purchase data, all of your consumer data, all of that stuff, which is pretty accurate about who you are.
Well,
you know,
but race
financially.
and ethnicity are notoriously difficult to get right.
Yeah.
I mean, we've spent many months working on this stuff in the past year, 2 years, and there are so many different variations on the theme about who's actually collecting the data. Are they asking the person, or are they doing it based on their own observation or impression? Even if they're asking, does the person feel like they trust to answer in that setting, honestly? And then you've got huge limitations in the CDC standards there, because, for example, if someone is truly multiracial and they tell you that, there is no place in the CDC standard for a multiracial person.
Right. Right.
And
And it's
so-
also based on self-attestation in a lot of times and how they've attested
Yep.
in one case versus another case. Yeah.
Right.
Yep.
And people don't really understand, honestly, most of the time, what ethnicity really may mean.
And a
you know,
lot of the
get-
systems simply don't have places to record multi-ethnicity issues. And
Right.
Spanish in some systems is an ethnicity. Sometimes it's an indicator. There's lots of variations out there, and not everybody follows the census standards.
Right. So I'm
Let me go-
surprised
let-
they're at 82%.
Let me go to Denny here and see how Massachusetts is doing it. You got any goods for us?
Yeah, what we're looking at, and we're working with a health plan and a group of their provider networks on, a self attestation model, so that patients are the ones who provide their race and ethnicity. That's all they're looking at. The health plan is just those two data elements, which, as has been discussed already, are enormously complex in and of their own right. But, this is an area where we see, a number of problematic issues. One is that analytical approaches to race and ethnicity generally get to, at best in the 80% when it comes to capturing with reasonable accuracy what the race and ethnicity of individuals are. Patients, members, people are very distrustful of this question being asked of them, and wondering why. Is this a form of redlining? Is this a form of some form of institutionalized discrimination at worst? So, there are other challenges when it comes to race being not a real thing, but a construct, and that ethnicity is a real characteristic of individuals. Race is an imputed characteristic that people tend to use, but doesn't have any relevance from a validity perspective. So I think from what we're seeing in Massachusetts is a bias toward bridging the gap between payers, providers, and consumers, so that the underlying reasons for collecting and using race and ethnicity data, among others, is firmly grounded in practices that the individual can support, and that there are firm and clear assurances that the data are not going to be used against them. And there need to be some legal, in all likelihood, some legal work that healthcare organizations are going to have to prepare themselves for, to indemnify themselves from the risk of doing this incorrectly. I would say lastly that we see this, and Pooja can appreciate this, we see this as an effort that requires, an incrementalist approach with a small population of physicians, patients, and payers sitting together and saying, how do we start carving out small enough implementations of this so we can understand as early as possible and with as little damage as possible where we will stub our toes, what are the analytic issues that we need to understand, what are the cultural and sort of historical issues that we need to address. So you know, in Massachusetts, we're probably struggling with the same things that everybody struggles with. And we are trying to do this in as collaborative a way as possible, where patients are part of the discussion so that how they consider themselves in terms of race and ethnicity is as valued a part of the conversation as the perspectives of the organizations who are collecting these data.
Yeah, and I think that really ties in, right, to some of the things we've been talking about here too. And I think, you know, that kind of having that patient voice. I mean, we talk about this all the time in this group, right? And not only that, I think what Denny mentioned about, you know, just kind of, you know, we need to get out there and start implementing some things and trying things. And I think that was kind of my biggest takeaway yesterday out of the sessions was, you know, there's a lot of people doing a lot of great things. And I think, you know, now, you know, in talking with Trisha Lee and Stefan, I think, you know, it's trying to understand now kind of what's out there, what people can start implementing. And, you know, I mean, now consent and this identity management is touching everything that everyone's talking about. So, you know, get out there and get some real world, you know, implementations, get some real world lessons. I mean, that's in a way what, you know, we keep talking about here too, right? Of you know, in New York and other places of how do we bring those lessons back? So.
So I want to follow up, Pooja, with you know, sort of thinking. So what's next, right?
Yeah.
And because I agree. I think I was pretty outspoken yesterday about that.
It was good.
Okay.
I was cheering you on off camera.
All right.
Like, come on. I mean, I love talking about all this stuff, but
Yeah.
I just feel like, okay, let's start doing now. I mean, I think that's part of the thing, right? Let's get some
Exactly.
lessons learned.
Exactly. So how do we do that? I mean, I know what we're trying to do.
Yeah.
But how do we? Go ahead.
No, I don't know. I mean, to me, again, I think part of ONC's goal out of yesterday was to try to get their arms around everything, because there was, you know, there is a lot. And I think we've all been kind of talking about it in different circles, in different areas. Now you've got ONC coming in with kind of that broader view. But I think, you know, we just kind of, like, to me, I think this group is one of the great groups that's kind of out there actually doing some implementations and people are involved. And I think I mentioned this during my portion yesterday, you know, it's hard for people to grasp, right? It's very conceptual still, I think. And I think the work that we're starting to do around the, you know, the early education stuff, you know, like get some workflows out there, get some people doing stuff. I mean, that's what we were able to do with advanced care planning was get that into, you know, in that case, it was BPM Plus. They turned it into an operational workflow. You know, what can we do now? And I think we've got some great insights. And, you know, Christine, when I was listening to, you know, what the takeaways were from your small group, you know, there was like some real tangible, okay, here's what we need to focus on and here's what we need to do. And I think that's kind of where we should be thinking about focusing next, right? Or taking some of those key takeaways and saying, okay, how do we now implement? Of course, there's always the issue of funding and all that, but I don't know. That was just kind of initial. I honestly haven't really thought through kind of, you know, where everything goes next, but those are just some high level thoughts that I had coming out of yesterday.
Yeah, and Mary Sarah brings up a great question in the chat, which is, are they all just pilots? And
Yeah.
I think there were a few people in a couple of chats who are like, oh no, such and such is doing this. But I mean, LEAP CDS were all pilots and they were
Yeah.
funded pilots. And I mean, you know, speaking as a technology guy and a former vendor, pilots are where ideas go to die a lot of times. You know, it has to be translated from a pilot to a strategy and an implementation strategy. And, you know, and as Ryan and I brought up yesterday too, it doesn't have to be just ONC sitting on this. ONC can coordinate with HRSA and CMS and
Yep.
CDC and everyone else with a chunk of this, because it's It's known. We were all talking about it. We had a room full of people talking about consent important.
I thought that one of the most striking parts was how they opened, and it was like they had this massive sign that was like, treatment payment of operations don't have to record consent. You know, like,
Our starting position is none of this is
by
required.
the way, none of
Right.
this matters. And then it was like, okay, now let's hand it off to the like I'm just gonna exaggerate a little, the edge use cases, right? And so I think part of one thing that might help us in terms of, you know, getting funding and getting more attention to this issue is that when we talk about consent, everybody who's knows HIPAA is like, what do you mean everything happens under treatment, payment, and operations? Or at least that's what their experience is, right? And this stuff, so that I think reframing it as like, well, release of information, we need technology to ensure secure, you know, we need standards to ensure that there's secure release of information in accordance with laws and regulation and patients' consent choices, right? That, I think, makes it a bigger, it kind of changes the framing a little bit. And because I keep on thinking, like, so many people, when we talk about consent, they think about a very small subsection of use cases, like around 42 CFR Part 2, for example, where that exchange of consent data becomes absolutely essential, right? Anyways, just a thought. I don't know, what do people think about messaging?
I think you're right, Matt, and I would offer, I mean, John Murky was on, which was fantastic, and John has contributed a tremendous amount in IHE and HL7 over time, and security and privacy and consent, APPC and BPPC and the others, but those are clinical use cases. And I think, like it or not, we got into some of those more murky ethical issues, especially as we address here about the balance between, you know, health and human services and the relationship between those services and where consent comes in back to health and clinical data. It's all not just simply clinical workflows and informed consent in a HIPAA type environment.
Yeah, I agree. I totally agree with you, Jim. You know, and organizations are going to have, like, every electronic system, is, whether it's healthcare or human services, will have some way of recording, I've collected consent, right, for this particular client, person, whoever, right? That where this concept of the consent utility comes in is, when do we need to, like, exchange this data, enforce consent? It's kind of taking it that step further to the standards level and to the enforcement and to all these other nuances. And so anyways, so I totally agree that there's multiple use cases. It's just,
yeah, and I think you may have been, I know there's a couple of folks here who were in the same session I was, where we kicked off. I think it was that very first breakout room one after the plenary, where Sue did a survey and said, okay, raise your hands electronically if you're just using paper-based consent collection. And about half the room raised their hands, and then asked about, are you using apps for it? And I said, well, that's fine, but remember, whether it's an app or a wet signature, it's the same workflow. You've got some document, electronic or paper, that just says, I consent to give all my stuff away. That's not getting into the sort of dynamic allocation of consent that we really want to get to, which we talked about at the end, realizing the whole room is still using paper.
But I think that's the key, right, to the messaging. I mean, there's, like, I can visualize a picture, right? Because there is that whole, you know, what's still covered under HIPAA, right? You're sharing, you know, records between the payers, the providers. But as soon as the patient says, I want to share it with an app, I want to share it, you know, outside, or you pull in the external, you know, the other HHS, like you said, organizations, right? It's almost like this divide, because then you're in this, like, whole different world where it's not covered under HIPAA, right? It's under the FTC in terms of, you know, enforcement. It's, you know, opening up the records. Like, it's this visual of, yes, this is still covered. We don't, you know, the consent is not as important, but, you know, we're in a totally new world now with the 21st Century Cures Act that's now opening up all this data. And it's like, it's this whole free, you know, kind of a free for all, unfortunately. So I think that messaging is really important.
You know, I'm having maybe an epiphany of sorts here. The this this shot here, right? There was cursory discussion around the non-HIPAA covered entities. One question I have is this actually representative of the percentage of services or dollars that are, or number of people or interactions that occur, or is it just sort of for, sort of discussion purposes? Because what I'm hearing in this conversation, hold on, let me make this. Can you read? You can see this, right?
What does the footnote say, Daniel?
Yeah,
That's the important thing.
a little too damn small. Let me just make it bigger here.
No, it doesn't. It doesn't give an explanation of how they came up with those proportions. So I don't think, I mean, these are equal proportions, right? So they're just throwing them up there, not proportionally.
Right. But what this conversation, what Pooja was just saying, and Matt and others were saying was, we almost need to carve out for ourselves that, I mean, from a positioning perspective, it's really not about the HIPAA covered entities or the business associates.
Other than specially protected health information. So we've got specially protected health information and we've got non-HIPAA covered entities. Yeah.
Okay. So that's our territory, right? That's our world. And it's almost like, in Yiddish, you'd say, go figure that out, on the healthcare side. And then just tell us how you're going to share the healthcare data that we need, the pieces of it that we need when we need it, right? Because the issues of whole person care or social determinants or social needs or all of that, sort of multiple system involved people and families is all in that blue box. I mean, it touches the healthcare stuff, of course, but it's the coordination around that. And I think as we talk about what the work is that we're doing, that's kind of what I felt yesterday, was there was recognition of Unify as being a persistent voice around the blue box, right? The blue triangle, part of the triangle. And that other people recognize it, but they dance around it. And not to say that we've got our arms around it, but we've got a lot of arms, we've got a lot of arms trying to wrestle this thing to the ground up against the gigantic healthcare HIPAA entity, that's all they're caring about, which kind of goes to that whole conversation around how do we demedicalize the conversation?
Yeah.
Right?
Well, I wonder, what about all the non-CGIS entities and the non-FERPA entities? I mean, what happens to that data when it goes to healthcare entities? What's required for them to be able to, store that data? There's no discussion about that. But I mean, I agree with you, Daniel. It's a very narrow conversation. And what concerns me most about that is the benefit of SDOH is preventative. And as long as we start with healthcare or the physician visit, we're losing the prevention power that we have when we share data.
Yeah. Right. So I think that definitely, right? Our Thompson family, right? It's all about getting upstream and doing a little bit of this and a little bit of that, and just changing the trajectory of their life. Maybe a lot, maybe a little, maybe some, maybe none. But I want to go back to the ONC and CMS and Children's Bureau and all, that whole federal participation, because I think without that, first of all, I don't think ONC can do it without participation from some of the big, from CMS and from ACF and from HUD and from, certainly CDC to a certain degree, but that to a lesser degree in terms of the social services, I think. Whatever, there's a lot of different federal entities that need to be brought in and could fund this, right? They all need to fund this. That was my point, which is let's stop recreating the wheel here. Everybody needs, if you want to deal with the SDOH stuff, we need to deal with consent, and it's ugly and messy and on paper. And how that intersects with healthcare is one thing, but how it intersects with each other is the bigger, is a more complicated question. So I don't know if that's a fundable thing. I think people will readily acknowledge and say, yes, that's, take that hill and that's the right flat. But it's not necessarily, a combat unit, right? There's no, I keep calling it the interstitial tissue. How do we get the entities to recognize that and to fund that to the degree that, whether or not it's the ink sites we've talked about, the mom sites, the other sites that are happening in Massachusetts, and the stuff that that's happening in New Jersey, and there's a bunch of places that could really move this conversation forward at scale. We're talking about at scale. It's like these places are already, they just need to be stitched together in some ways. So is that our role? Is our role to sort of continue to carry that water and then to go do it in places like New York and Minnesota?
And all the behavioral health care coordination stuff that's been funded in a big way over the last 2 years.
Yeah. I mean, that's my inclination, is that there is not another entity out there that can actually have the breadth and the depth of the conversation around social care that this and this expanded group can, and also intersect with the healthcare and the education of the justice communities. That ought to be, that I think that's clear to ONC, right?
I think that's why they kept talking about you.
All right.
and putting pictures of the consent scan up on the screen and all
Yeah.
those things. I mean, in theory, right? They coordinate across not just HHS, but other agencies, but they're not really funded and staffed to do any of that in a robust fashion.
So, right. So that is, thank you for reminding me. That was wonderful to see that. I think a very tangible thing is to take that, the scan, and actually just sort of make it available as the aggregation tool, right? Wherever that needs to sit for best practices, and or at least to start with that, because that's I know we all know how much work that was to put that together, and sort of start with some other tool. I mean, we can connect the dots on that, but that's very real, that everybody could use. Everybody can contribute to that. But again, I don't know if that's part of the accelerator world. I don't know if that's part of certainly doesn't seem like part of the fire world. And does ONC do anything non-fire related? Or is it all fire or HL7 all the time?
Well, you have TEFCA going in a non-fire way,
Right.
roadmap, but I mean, I think that if TEFCA gets the adoption that the federal government hopes that it will get, and we are a few years into TEFCA, at some point you have to put a consent piece in there when you're expanding beyond SDOH, right? That might be the mechanism to take something like that to a larger scale when you start looking at other purposes. But I think defining the use cases where where there's an urgent need from the SDOH sector to share the data, from the social care sector, right, to share the data with healthcare, as opposed to social care referrals, which comes from clinical to social care, and finding that urgent need, because then you have these other laws where treatment payment operations does not come in. You have,
right,
but I don't know.
All right. Well, one of the things I wrote on this one slide is Aaron Swenson. Does anyone know or interact with Aaron?
Yeah, I was just in a meeting with him.
Okay.
Yeah.
Because I don't know if he works with Miriam Yeager, who was really involved with TEFCA. I don't know if she's still doing. I don't know if Sequoia is still doing TEFCA.
Sequoia is still doing TEFCA, and as I understand it, Care Quality wants to qualify as a QHIN, or maybe somebody here can correct me, but Aaron leads Care Quality.
Uh-huh. Well, so that's another part of, what I learned from yesterday was, again, first of all, they didn't reference the in the TPO. I sent the facilitator, I forgot her name just now, a note about what we learned from Chris Albatrani, which is around care coordination under HIPAA, and how to use that. It's that should be part of it. That should be a very clearly defined role within healthcare to be able to do that. And I don't think it's well understood or used, given the fact that she didn't put it up there.
This isn't a criticism, but speaking as a member of the technical advisory board, our focus is on health information exchange and TEFCA and HIPAA compliance for processes. We haven't brought consent to the fore as part of any of it. We're just trying to make sure we match the right patients to the right records at the moment, which is understandable. I mean, that's a fundamental mechanical requirement. But I think it comes back to the fact that there isn't any mechanism that requires care quality or care quality members to have to do consent, at least not from a HIPAA standpoint.
Yeah.
And that's created a huge problem for New York to participate in care quality or any of the national networks, because they're not set up to handle New York's consent requirement for the HIEs.
Yep, that's exactly right.
And so they've actually accused we were not a member, but several of the other QEs were, and their membership in eHealth Exchange got canceled by eHealth Exchange, and they filed information blocking complaints, despite the fact that our consent requirement is a law. It's a state law followed with regulation that says we have to have consent for the HIE to release any data. And they were accusing the New York QEs of info blocking because we're requiring consent. I mean, it's ridiculous, but and part of it I find absolutely bizarre, because it completely puts them out of exchanging any substance use data in the national networks while this country is in an opioid crisis, which makes just no sense to me that that's not enabled. So,
okay.
Yeah, and with all the opioid money that's being allocated currently, they're losing out on that.
Yep. I think Denny, you were talking a minute ago about the use case where the social care network or somebody needs to get information to the healthcare folks. I'm doing a lot of work on the flip side of that, where the social care network is using the healthcare related data to prioritize what services and how they provide services to their clients. So they're getting, for example, our predictive model risk scores for high ED utilization on homeless shelter people, and using that to inform the staff about, who should you have more conversation with about their healthcare and how they're managing it, and, get them to the urgent center instead of they're going to the ED or something. So, and the CBO is not a covered entity, so it's not covered by HIPAA. For us to give them that data, they have to get the consent, and they are making a huge difference in people's lives because they're able to intervene based on knowing the healthcare information. So that's, that one is one of the ones I usually use in talking about this as being a compelling need for them to have access to the healthcare data in order to provide the social care intelligently and efficiently.
So I think for me, the just the drive, I'm sure there's going to be follow-up, and I'm sure they're going to look for feedback, and I sure hope that ONC sort of advances this work and recognizes this was just sort of the tip of the iceberg. I'm pretty sure Tricia, she said that certainly a million times. Like, we're just getting started here. So the question is it another 6 months? Christine reminded me yesterday that this one was supposed to happen last December, before the new year. This consent workshop was planned for. We talked to Stefan about it. We'll do it before Christmas. I think he said before the holiday break. Like, okay, right. We're all over.
Daniel, you forgot to ask which Christmas.
Exactly. Although he was pretty set on it being last year. So, well, I'm encouraged.
They got there, and they also, they did that plenary on health equity, for better or for worse, led to some interesting chat conversation. But I think that was their way of also leaving that opening for the next piece, in addition to like having you and Jim on the final panel, where you could also reopen these issues. So I think they were pretty deliberate in opening the door, even though the scenarios themselves were so restrictive.
Yeah, right. Well, I think that the door is open to sort of continue to focus on this, on the social care. And when I use that word, I mean education and justice as well. So to focus on that, and that's a unique place for us to be. And I think maybe we can. And I know I have some calls coming up with some folks from HIMSS. We're continuing to talk to New York, Colorado, and California. There's a lot of conversations going on, which is great. But we need to also then, like everybody, find resources to do the work. We need to implement it in New York, and we need to implement it in Minnesota. We just have too many. There's too many things aligned to go not to do the MVP there. So we need to get over that hurdle, and maybe there's funding opportunities. I think Medicaid should be paying for this. This is helping. That's the population that's going to benefit from a lot of this care coordination, hopefully. So we'll kind of stay tuned. Hopefully we'll hear more from our colleagues over there. May do a couple of blogs, or if anyone's interested in doing post-event blog or an article for the newsletter, we can put out there sort of reflections on that, or just even simply the social media work, opportunities to comment on things, because there's a little bit of work a little bit of commentary going on LinkedIn and stuff like that as well. And I know some of the ONC folks are fairly responsive in there as well. So I sincerely hope that we continue to move this forward. And next week, I think, Mary Sarah, I was going to actually ask, I won't put you on the spot here, but I'll put you on the spot, that the digital locker folks.
Yeah.
I'd love to see them present.
Okay.
And maybe I could email back and forth with them, but I didn't ask them that. But if you have a chance to talk with them, maybe
Sure.
they can do it, because that addresses those boxes that Brian drew into our architecture diagram, which is pretty much what we're talking about here.
Yeah.
I'll offer in Mary Sarah's defense, as well as mine, and I know a few others here, Civitas closes out at noon, which is 1 p.m. Eastern on Wednesday.
Oh, okay.
And I don't know what everybody's plans are going to be I'm going to hop in the car drive home. I don't know about Mary Sarah. If you
Yeah.
invite her.
I'm going to be on an airplane.
Yeah, I'm going to get on a plane too. So Daniel, I can probably have them speak. I probably won't be able to join, but decide. You might want to look to see who's going to attend, and if you want to postpone it a week, or
Yeah, maybe we'll postpone next week.
Okay.
And we'll look at the end of the last week. Yeah, if you can make contact with them, because I just thought that was really a cool part of.
Okay.
part of the solution there, and we'll keep posted with everybody.
I will do that.
All right. With that, have a great rest of the day. Welcome to our new visitors. Please come back. If you've got contributions to make, we welcome them. Just watch out for our emails. Okay. Have a good day, everyone. Talk to you later.
Take care. Nice to see
Thanks,
you.
Thank
everybody.
you.
Bye.
Thanks.
Bye.